will give us this talk about distant imaging of local advanced prostate cancer in the era of next generation imaging. The floor is yours, Dr. Anwar.
Good afternoon, everybody. Okay, so you can see Manal gave a very nice presentation of the use of PSMA PET-CT. The question that I'm going to pose to you today is whether you should use it or not in locally advanced prostate cancer. So here are my disclosures again. So let me introduce you to Umar. Umar is a 76-year-old man. You can see that he has a locally advanced prostate cancer. It's high risk. Look at the Gleason score, 4+5. And I've just shown you some images of him. You can see his CT scan, you can see his bone scan. So the question I'm going to ask you is, now that you've heard about PSMA PET-CT, should you use PSMA PET-CT for Umar to look for metastatic disease? Definitely yes, maybe, you're not sure, maybe not, definitely not. So those are your options. So who says, after listening to the lecture, that you should definitely use PSMA PET-CT for somebody with locally advanced prostate cancer? So definitely yes. Who would definitely use PSMA PET-CT? So 1, 2, 3, okay, 3, 3.5, maybe? Okay. Who says they are not sure? How many of you say you are not sure whether you would use PSMA PET-CT? 1, 2, 3, 4, okay, 5, 6. Okay, how many of you say definitely not? What about the oncologist over there? You would answer what?
I was uncertain, yes.
You are uncertain?
Yes.
Okay.
I raised my hand in the uncertain.
Yeah, okay. So the question is not whether it is licensed for use. The question is, should it be used? And that's a very different question. Now, this is Umar again, right? So what are his therapy options? Okay. So what you have to remember, Umar is in a spectrum of disease. So he has high volume, high risk, locally advanced prostate cancer, which on bone scans and CT scans is M0. In other words, he has a very good prognosis. But we have to acknowledge that he is in a spectrum of disease from low volume to high volume metastatic disease. So Umar is at one end of this spectrum. So what are his therapy options? His therapy options, in fact, are pelvic radiotherapy with a limited duration of ADT up to 2 years. That is his primary treatment. If he had metastatic disease, he would need other types of treatment, including systemic therapies. And all of these therapy choices are decided on the basis of a bone scan and a CT scan, not on the basis of next generation imaging. That's the important thing to remember. So for example, if you look at the use of docetaxel in somebody with locally advanced prostate cancer, you'll see the greatest benefit is in a man with locally advanced disease. So in other words, where the blue arrow is, the benefit for lower volumes of disease, it's much less for the use of docetaxel. In other words, in this state, the bone scan and the CT scan is predictive of benefit. In other words, it's a very strong biomarker. Look at this scenario. This is looking at bone scans and CT scans predicting the value of prostate radiotherapy. You'll see if you have low volume disease, there is a benefit to giving prostate radiotherapy. In high volume disease, there is no benefit. In other words, bone scans and CT scans are predictive for the use of a therapy. This shows you data on the use of a bone scan and a CT scan for a limited duration of ADT therapy post-radiotherapy. And you'll see that bone scans and CT scans are prognostic. So I've shown you that in this condition, a CT scan and a bone scan is predictive and prognostic. Where is the data to show you that PSMA PET CT helps? There is zero data, nothing available in the literature. So why or when should you use next generation imaging? If you look at the ESMO guidelines say patients with high-risk, locally advanced prostate cancer should be staged by CT scans and bone scans. And you should not deny patients local pelvic treatment on the basis of stage migration due to a PSMA PET CT. Be very careful. And in fact, if you look at the ASCO guidelines say the same thing. Conventional imaging is first. And if you have a positive result, there is no compelling reason to use a PSMA PET CT. No compelling reason, no good reason. But you can think about it in somebody who is at high risk of disease. Now, somebody like this. So this is a patient from Dubai who came to London. And what you see is a locally advanced prostate cancer. And in Dubai, you can see he had a apical tumor that is PSMA positive. Okay? Does this give you information about treatment? The answer is no. Let's look at the basal part of this tumor. The basal part of this tumor is PSMA negative. So the apical part is positive, the basal part is negative. And this lymph node here in the left internal iliac region is negative. Right? So you already know there is a differential expression of PSMA PET in a locally advanced prostate cancer, and this is a false negative for PSMA PET. Because on the MRI, it's very clear that this is a metastasis in an internal iliac lymph node. Now, what you have to remember is that small lymph nodes are regularly missed by a PSMA PET CT, regularly. In fact, the sensitivity you can see on the ROC plot is only 50%. And if you have small lymph nodes, you miss the majority of involved lymph nodes, the majority. So the question you have to ask is, are these small microscopic lymph nodes important? Are these important? And the answer is yes. Yes, because if you alter the treatment on the basis of a negative MRI, on the basis of a negative PSMA PET, the patients survive less well, and this is a prospective randomized study. So you can see in a prospective randomized study, patients do worse if you act to de-escalate the therapy on the basis of a PSMA PET CT. So in other words, be very careful about de-escalating therapy on the basis of a PSMA PET-CT. It is okay to escalate the therapy, but do not de-escalate. Otherwise, you will do patients harm. Okay. Now, another circumstance is this circumstance. If you have a locally advanced prostate cancer and you are suspicious but not definite on a conventional image. Let me show you an example. So this is a guy who flew in from America. You can see he came, he has a locally advanced prostate cancer, high risk. Look at his PSA, 3. His PSA is 3. Now, there are 2 lesions you can see on the bone scan, but they are negative on the CT scan. So these are unconfirmed bone lesions on conventional imaging. Now, this is a very good circumstance, right, for doing a PSMA PET-CT. A very good circumstance. And when we did the PSMA PET-CT, what do we see? A negative CT scan, a positive PSMA PET, and a positive MRI. So this man definitely has metastatic disease. And if you look at the spinning image, you'll see he has about 10 deposits. Okay, so we now know the truth. Yes? We now know the truth. We know the true load of the disease this patient really has. But do we have clarity about the treatment? In other words, would you treat this man with pelvic radiotherapy? Because remember, I showed you that if you have polymetastatic disease, you do not benefit from pelvic radiotherapy. I've shown you that data already. So will you withhold the pelvic radiotherapy? Now, you see how you have created confusion in your oncologist's brain. Number 2, how long should he treat with adjuvant ADT? 2 years, which is what he was going to do. Now you're showing polymetastatic disease, so you are now forcing him to treat for the lifetime. On the basis of what? 0 evidence. Number 3, I told you that chemotherapy is a valid option for locally advanced disease, and in fact chemotherapy is a valid option for polymetastatic disease. But this is microscopic polymetastatic disease. You can't see it on conventional imaging. Is it still valid? Is it still a valid option? Do we know? The answer is nobody knows. There is no data. Remember, be very careful about your tests. But we get patients like this all the time. A patient comes with an MRI and then a PSMA PET-CT, no conventional imaging. What should you do? You can't, if you already know the burden of disease, the oncologist can't go back and do a bone scan. That would be ridiculous, right? What do you do? Okay. The important thing from the radiological perspective is to pay attention to the conventional part of a PSMA PET-CT, right? Because that is going to be determinant. Number 2, the decision to treat the primary tumor is based on the CT component, not the PET component. Remember that. And that is what the guidelines are now saying. On the other hand, the high specificity of PSMA PET cannot be ignored. So if a PSMA PET-CT says this is metastatic disease, you have to consider it. In other words, the high specificity, in other words, the positive result is an actionable thing to escalate therapy, but not to de-escalate. That's the important thing you have to remember. So the take-home points are here. Number 1, the new generation of technologies, PSMA PET-CT or whole body MRI, has a potential to change the course of the disease. However, we do not know, we do not have level 1 evidence. Remember, you will be stage migrating a lot of people, and lead time bias is a real issue. There are circumstances when you should use PSMA PET-CT. Number one, especially when you are not sure about conventional imaging. Remember that therapy escalation due to high specificity is something that you should exploit. But do not be very careful of de-escalating therapies on the basis of a negative PSMA PET-CT. And in fact, if you look at the last line here, the EAU guidelines, the latest guidelines say when a PSMA PET-CT or a whole body MRI is used to increase sensitivity, beware of the lack of outcomes data on any subsequent management change. This is a very important lesson. So use it to escalate, but not to de-escalate your therapies. Thank you very much.
Thank you, Professor Padhani, for this very informative lecture. Before we move to the next session, any questions regarding the PSMA and its use in prostate cancer? Any question from the floor?
Thank you so much, Dr. Padhani, for putting us in more dilemma about the use of PSMA. Before your lecture, I was uncertain, and now I am very uncertain.
Yeah.
But yes, you have mentioned it clearly. If you use the PSMA, you can escalate the treatment, but up till now, do not de-escalate your treatment. How soon do you expect that the PSMA will be involved in the guidelines and replacing the conventional imaging?
So PSMA PET-CT is already in the guidelines regarding biochemical recurrence, as Manhal pointed out. With regard to locally advanced prostate cancer, there are no prospective clinical trials. There are 2 or 3 trials that I'm aware of that are now ongoing. When they read out, we will know. Then we'll have level 1 evidence. The issue is, what is the endpoint? If it's metastasis-free survival, which I think is reasonable, that may be an appropriate endpoint. But the regulators are in fact asking for a survival endpoint. The problem is, once you get to a survival endpoint, then that is delayed by many years. And so it depends on how the guidelines committee will look at this. But 2023, they are saying you can use it because it's approved for the indication. But whether it actually makes it into guidelines and changes practice, that is a completely different question, as you know. And this is something that is constantly debated in the literature. Yeah.
Any other questions?
Yes, maybe I'll go in also even to the earlier lectures too, because I didn't have the chance to ask Dr. Perez for the PSA density. I like the notion of using PSA density for the using the MRI and performing biopsies on Pirate 3 or not. PSA density was usually measured by transrectal ultrasound. But in the current hierarchy, we go from the clinical tests and abdominal ultrasound to PSA, MRI, and then the transrectal ultrasound and the biopsy. So what's your...
Yes, PSA density is for me a critical thing to know when I do the interpretation of an MRI examination. So I always want to know the PSA of the patient and the PSA development. Because as a radiologist, I want to know the risk that the MRI that the patient is positive. So let's assume I have a PSA of 12 and the patient has a rather small prostate, and you can measure the prostate with MRI. You can use segmentation, which is a technique which has a very low inter-reader variability and is very accurate. Based on volume and PSA, you can calculate the PSA density. So if the PSA density is, say, more than 15, or when it's 20, I get a little bit nervous when I don't find anything on the MRI. And I look again, I look again, I look again. So I want to increase my reader sensitivity, which is important. If, however, the PSA density is very low, then I'm happy if I find a Pirates 2. Now your question is, what about the volume with TRUS and the volume with MRI? And with MRI it's a little bit more accurate, but with TRUS you can calculate the volume. And now we are faced in a situation that we don't have enough MRI machines. We don't have enough machines to help everybody in Egypt. And so we have to make a selection at the door which patient will have an MRI or not. How will you do that? Well, you do it with PSA, yes. But if you have a PSA of 20 and if my prostate is 200 cc, my PSA density is 0.10. Then all the PSA which is produced and which is in my body is produced by a normal BPH. So in that patient, it doesn't bring anything. So I'd rather would like to have the PSA density. And for that I need to have a volume which, if possible, is being assessed by a urologist with TRUS. So yes, I'm a little bit reluctant. I'm looking for a way to select at the door the patient who will not have an MRI.
And can't we do it the volume with the MRI, sir, and put the PSA density?
You can do it with MRI, but then you did already an MRI. But now we have the situation where we don't have enough MRIs. You don't want to do a patient in an MRI with a low PSA density. So you need to have some kind of an, assessment of the volume. And that is by TRUS. So
do you wanna do TRUS before we do the MRI?
If you have limited MRI, you need to find a way to reduce the number of patients. Do you have a solution, Anwar?
Professor Ala is in our program. Yeah. Okay.
So one way of tackling it is do a free to total PSA. But free to total PSA is only being shown in the gray zone of the PSA between 10 and 20.
20, yeah.
So that might be a solution, but it's not a great solution. The other ways of doing it are things like 4K tests and the Stockholm 3 test, but those are hugely expensive.
Yes, more expensive than MRI.
And they don't work. So, there isn't an ideal solution. And I think Yeli's suggestion of a risk calculator is a good one.
But again, the risk calculator needs to have the volume of the prostate.
No, well, depends. It depends. The risk calculators that predict the risk of cancer do.
Yes.
But whether you're at high, intermediate, or low risk, you can do that with some risk calculators without the PSA, without the prostate volume. But they're not great. That's the problem. They're not great. It's a circular issue, but there isn't an obvious answer.
Okay, my next question is.
But this answers your question, Professor Ala. This can help us in our program, because we cannot do a TRUS for every patient for screening before. So we are using the PSA.
Screening. Maybe I was more inclined to see, can we measure the PSA density with abdominal ultrasound or pelvic ultrasound? I mean, will it be accurate? But the error is so high in measuring the prostate. It's plus or minus 25%. So
In a sense, does the inaccuracy of abdominal ultrasound impact the sensitivity of the test? That's the question. I mean, you won't get an exact PSA density, but you're looking for a cutoff, correct? So if you have a systematic error, there may be a way to say, okay, I'm willing to accept an error of X. Because the triage is plus or minus MRI. It's not, the triage is not plus or minus biopsy. So you may, I mean, that's one way, it's a way of thinking about it. I don't know how well it would work.
There is a situation in the Netherlands, in the Rotterdam area, where Professor Bangma is introducing the volume assessment of the prostate by trust, not by a urologist, but by an expert ultrasound person. So he or she is specially educated to measure the volume. And well, he's trying to solve the problem in that way. In the meantime, I'm trying to solve the problem in a different way, that if I see that there is not enough MRI capacity, and if I know that MRI is the best, I'm not closing the door by introducing the PSA density, but I'm trying to increase the number of MRIs by the techniques which I've shown. Perhaps no contrast, artificial intelligence, speed up the MRI examination, be more effective. So yes, this is the solution I would choose for.
Yes.
I think one of the other problems is all the level 1 evidence in the screening setting is on PSA and not on PSA density. The biopsy data is on PSA density.
Yes.
So I don't think anybody would criticize you for not using a PSA density as the entry point. A PSA should be enough because that's where the level 1 evidence is.
And Professor Ala, you're on the program, and you say that you would like to do that the PSA after 20 will not do an MRI. You said so. After 20 PSA.
I think this is our preliminary decision, but I think when we start getting data in, we might adjust this because we still don't know how many we're going to get, especially we're still in the first round of screening.
I was still in the pilot phase. This is true. That's good.
What we got until now is that 100% of people above 20 were malignant, and without an MRI, and around 65% of them were only 25% were stage 4, which is also was something that we discussed. Yeah, and we do have a very long wait for the MRI. However, yeah, it's not about the decrease in capacity of MRI. However, you have to upgrade the system while you go, because it was not optimized in terms of human resources, in terms of technician, in terms of the usage of the machine. So we do have to discuss this, but the real assessment would be at least 1 year from the day we started. So we'd be able to say if the system is able to sustain and withstand this recommendation, we can upgrade it to the standard of care, or we have to customize it more.
Yes.
At this point for screening, the EAU advises the level of 3, which is just a cutoff level for everybody. In the clinical situation, of course, you like to have the PSA velocity. What happens in time, that's even more important.
Yes, we do that. We do the velocities, of
if
course.
If the PSA is going up and down, it's prostatitis. If it gradually rises, but just a little bit, it may be BPH. But if it goes like this, then you should do an MRI. Yes.
Yeah, but we should be careful with velocity, because the most recent guidelines now, we don't take biopsies based on PSA velocity alone. We have to include we need other data to justify a biopsy, not only PSA velocity as we did in the past.
No, he means that we do the MRI. So we do the MRI. If the velocity is getting higher, every time the PSA is rising all the time, so this is an indication for MRI for sure.
Okay, I have another 2 questions regarding the biopsies and the MRI. For the biparametric MRI, it sounds very good for us because we omit the contrast and do a faster MRI study. But is there a situation where you would say that we need the contrast in this case?
So the question is when to use contrast or not. Well, I'm quite clear. You should always use contrast, except when you are an expert, that you know for yourself that your performance is good. How can you test that? go to the MDT every week and see how your results are matching with the biopsies and prostatectomy. So you need to be good. Second, only skip contrast in certain cases. In cases where the a priori risk is low in having prostate cancer and where the sensitivity is less important than the specificity, where you want not to have an overdiagnosis. There you can use contrast. When you have a high clinical risk, so when you really want to find a tumor, you need to have the sensitive technique as possible, and that is with contrast. So in any clinical situation, I'm using contrast. Not only because I want to upgrade a PI-RADS 3 to a PI-RADS 4 in the peripheral zone, but also because it increases my sensitivity. Sometimes I just see, okay, whoop, there's enhancement, then I look back, and then I find this small tumor which I would otherwise have missed. If you want to separate an anterior tumor in the fibromuscular stroma from normal tissue, so normal AFS from cancer, you need contrast. Also in the central zone. The central zone never enhances. Their contrast is also very helpful. And also when you want to evaluate invasion in the seminal vesicles.
Of course, yes.
So there's more than what the PI-RADS steering committee is saying, upgrading from a PI-RADS 3 to a PI-RADS 4. So yes, I'm using contrast always. And what I see a lot around me, unfortunately in my country, is that a lot of inexperienced radiologists, because they have a lack of MRI time, forget about the contrast. They sometimes have a poor quality of diffusion and a poor diagnosis. And that is hurtful for not only the MRI technique itself, but also for the patient. I hope that more or less answers the question. Do you have a different view, Anwar?
Yeah, basically I follow the PI-RADS committee recommendations. And I think Yeli is correct that you should use contrast when there's a high suspicion. In other words, you should use it in your symptomatic patients. You should not use it in screening. That's the most important. If you start using it in screening, then you will suffer from overdiagnosis and overtreatment. And in fact, your screening outcomes will be worse. And somebody will cut your head off. And they will stop the program. What you want to find in the prevalence round, in other words, in the first round, is that you'll find just locally advanced disease. There's no doubt, and high-risk disease, as he said. A lot of the patients you will find when you get to a PSA of greater than 20 will be locally advanced disease or high-risk disease. That's what you will see in the first round. What you will find is in the third round and the fourth round and the fifth round is that because the prevalence of disease will actually go down as you get rid of these initial cancers. Then you may find that you'll start to use it more and more. But what I would recommend is if you're doing primary screening, do not give contrast because the a priori prevalence of disease is in fact just 4% if you take all comers, and that'll go up to 19% if you have a PSA greater than 3. So you just have to be careful about giving contrast in a screening setting because it doesn't become cost effective. It takes longer time and it might actually do more harm than good. So I personally wouldn't use it in that.
Yes, in screening with contrast, you're too sensitive.
Too sensitive.
And you have too many false positives. And that's what you do not want to have in screening.
And that's right, the importance of the quality, as Dr. Yali said, the quality of the films, the training of the technician, the training of the young radiologist who is going to write the MRIs and mainly the technicians, because if the technique quality is good,
Yes.
we can easily deny the.
That is crucial in every screening program. That is the quality of the images. In breast, it was the quality of the mammogram. The guy who started mammography, Jan Hendricks, made a lot of efforts in improving the quality of the mammogram, which was 25 years ago very bad. That's one. Improve the quality. Look at the quality of the images. Use PyCall. I cannot emphasize this more. And second, your own quality, the interpretation. You need to be an expert. Because at this time we don't have AI with level of 1 evidence yet. It will come, but not today, not tomorrow, but next year.
So basically, this is the direction we took, because we're still at the beginning of formulating a national program, at which this point we are trying to be as cost effective as possible. We still have a lot of cases that are high risk and a little bit late in diagnosis. What we discovered is there is a little bit of a stigma with prostate cancer diagnosis also. So in order to do this, we are trying to avoid small disease that you find that would not be cost effective, that would cause overdiagnosis and would put you in a place where you have a patient that's doing follow-up, burdening the system without real intervention.
Yes.
But of course, as you said, sir, that later on we have to be prepared for this. And this is what we're trying to do with the team and with Dr. Mohammed, is that in the coming 3 years, we increase the capacity of human resources able to deal with MRI and MRI interpretation.
What you need to do is build up a reference center, which is the top of the knowledge, which can be used in all the other centers. All the other 9 centers will in a few years become reference centers as well. And with that, I offered, if you have a reference center, I offer to help you to have those persons being educated, both technicians. It's very important. Most of the time it's being forgotten. The technician is crucial.
Yes,
and
of course.
the radiologist.
Yes. Thank you, sir.
Another question here. I know we're short of time, but I think the discussion is quite interesting. We know now that still in the guidelines we do targeted biopsies and systematic biopsies. Maybe in the repeat biopsy setting, there is weak evidence that we may omit the systematic biopsies. But we know that there are some studies coming out now, and are we getting close to being confident enough to go just for targeted biopsies and
Yes,
omit the systematic biopsies?
A very good question. What about the combination of targeted and systematic biopsies? We've had that discussion in my country also. And just a few years ago, there was a targeted biopsy and systematic. But why should you stick in a needle in an area where on the MRI is no tumor? Please remember that if the MRI is good, that your negative predictive value and your sensitivity is more than 90%. So you are pretty sure that there is no cancer in the area where an MRI is negative. So why should you stick needles in that area as well? We also have been investigating, and not only our center, but are coming out, I think, more than 9 papers now have been there, which addressed the fact that instead of systematic biopsy, also in the area where there is the tumor, we should go to focal saturation. So stick the needle in the place where you see at the MRI where the tumor is, and stick a few needles around it. So 3 needles in the target and 5 around it. And the less certain you are with the MRI that shows a tumor, or with your own biopsy experience, the more saturation needles you should take. If you are a rather inexperienced urologist doing the biopsy, you should take, say, 5 or 6 focal saturation needles around the target. Because most often you see in that area where there is a more Gleason 4 component than in the target itself, and that is due to the biopsy needle error. No matter how good you are with cognitive or fusion biopsy, there is always an error. So focal saturation instead of targeted plus systematic biopsy. That is what we do in our institution, and now various urology departments in our country are following.
Okay.
What's your opinion, Anwar, in the UK?
Professor?
Yeah, so there's two systematic analyses that have looked at focal saturation versus targeted plus systematic, and there is no inferiority of the focal saturation approach. And there's two systematic analyses, and there's another systematic analysis coming out shortly. So and Yeli is right, the major reason that systematic biopsies tend to pick up cancers, it's quoted as 6% roughly in the Cochrane analysis. Some of those are just the same systematic cause that went through the main tumor anyway. So there's a double counting issue there. So the important thing to remember is the lesions that tend to get missed are the smaller diffuse lesions, not the larger lesions. So the current recommendations from the PIRADS pathway group is that focal saturation is a valid approach for PIRADS 4 and 5 lesions. Then the question is, how many cores do you need? So at the moment, it turns out that the number of cores you need is probably 4 if you are using in-bore targeting biopsy. That's what the current recommendation is saying. However, if you do fusion and ultrasound, then the recommendation is to go up to 6. It doesn't say 6, it says up to 6. So, and that is the direction of the movement as we see it at the moment. So you will not be criticized on the basis of 3 systematic analyses of doing just focal saturation biopsies.
Professor Padhani, Professor Leary, Professor Ala, discussion will never end, and we will continue, of course. And the screening program is still in the beginning, we'll go. But we now, Professor Patelli from Italy, he's waiting on the Zoom, and so we have to continue our session, and he will talk about the Ecolite disruptive patient treatment